another video from the CTAD Clinic. My name's Dr. Mike Lloyd and I'm the director of the clinic. Today I'm going to be addressing a question that gets asked of us a great deal, which is how do I access funding for therapy? Within the NHS, obviously there are a lot of free mental health options, but sometimes these are not available to people and they have to try and find funding for therapy in the independent sector, certainly abroad, either with health insurance or again in the independent sector. It's important to establish funding in order to get the therapy for the treatment that is needed. So this is essentially for the treatment for conditions such as Other Specified Dissociative Disorders and Dissociative Identity Disorder, OSDD and DID. Now, we know that doctors and commissioners of health resources are very evidence-based, and the video today is looking at a resource based on clinical evidence on an outcome measure that's published in order to be able to demonstrate the cost-effective use of services for dissociative identity disorder treatments. What this means realistically is that the example I'm going to be giving today is a way of being able to show health providers the evidence for the effective use of funding for these treatments. An additional benefit of this for therapists is that often short-term therapies are all that is available within many services. And this is a long-term study. So this is research that was conducted over a 4-year term of therapy, which is quite a long time in terms of many, certainly within the NHS. And what this demonstrates is that actually using a long-term therapeutic model shows the benefit not just to the individual receiving the treatment, but also to the local health economy. The resource is a publication. It's something that I published in 2015 in the Journal of Trauma and Dissociation, which is one of the best journals in the world for up-to-date evidence and research about trauma and dissociation. This is a peer-reviewed scientific journal. The research was conducted in an outpatient setting within the National Health Service in the UK and is based on two sets of case studies from individuals, both having been diagnosed with DID, both with extensive abuse histories from within their own family and childhood, and both consenting to take part in the study. It's essentially an outcomes measure. It's looking at the type of services and volume of services that were being used by these two individuals before therapy started, and then to look at the nature and volume of those similar services after therapy has taken place. And the therapy was conducted by me in these outpatient settings using the international guidelines for the treatment of dissociative conditions set out by the International Society for the Study of Trauma and Dissociation, ISSTD. The guidelines are referenced in the descriptions in the video, and also a link to the article I'm talking about. Now, the article is under copyright, so the abstract is available. There is a fee to be able to try and to download the article to be used. But actually, if you go to, for example, a library and ask them to do an interlibrary loan, they'll be able to get hold of that article for you. Your therapist might have access to the journal anyway if they have an Athens account and they can access research. The article is, as I said, an objective measure. It looks at the service use, so it measures attendance at inpatient clinics, crisis clinics and admissions. It does not take into account primary care, so GPs or emergency services or medication or referrals to tertiary centres such as neurology clinics or pain clinics. If we'd have had the resources to measure all that stuff, I think the results would have been even better, because we're aware a lot of time and money is spent on people accessing interventions such as, for example, MRI scans and blood tests and all sorts of different things. The research looks at 4 years. So it takes into account 4 years prior to therapy and 4 years following therapy. And it was really interesting how these results worked out. So if I put a graph up at the moment, what you'll see is a chart of the service use for one of the individuals in the case study over that period of 4 years, so between 2006 and 2013. You can see that in 2006, 2007, 2008, 2009, there's an increasing use of services. So basically, as this person's mental health deteriorated as a result of not being treated for DID, they had an escalating use of services. So we can see increasing use of wards, that's the inpatient psychiatric hospital services, and crisis out-of-hours services, so huge numbers. So in this one example, in 1 year alone, this person had over 180 contacts with the crisis out-of-hours team. That means almost once every 2 days they were using crisis services. You can see from the graph then the colour green is the introduction of me, the psychologist, doing the therapy for this individual. And what it shows is that with almost an immediate effect, there was a huge reduction in the number of services being used. So no admissions in the 4 years that therapy took place, huge reduction in the number of crisis appointments, and basically just sort of standardized, once every couple of weeks appointment with the local community mental health team. The essence of it is that the psychology, the specialised focused treatment for these conditions replaced all of the other things. So pretty much this individual was being seen in many different areas, and then when therapy started they were seen in therapy and everything else dropped off. So this had an enormous impact on this individual, both in terms of their quality of life, and it had an impact on local health services because it reduced the amount of money being spent on unnecessary things such as psychiatric admission days, which are very, very expensive. What the graph shows and what the research shows and what this resource shows is basically ruled down to this. It is more cost effective to do something for the treatment of DID and OSDD than to do nothing. That to leave an individual without specialised therapy has an increasing, escalating cost to local services, as well as all the quality of life indicators. And to do something to introduce funding for therapy to allow a person to be treated in a focused, specialised way over a long period of time, this is a 4-year study, remember, that actually reduces the cost. Now for this individual that I showed you the graph for, when we actually worked out the cost, after you'd factored in the cost of the psychological therapy, the actual cost to NHS local health services reduced by about £20,000 a year. That means that it's actually cost savings to the local economy to introduce therapy to a person who has these great needs. So a person who has a huge number of service uses like this, it's cost effective to provide therapy. That's the argument, that's the resource. And to be able to take that to GPs, to be able to take that to mental health clinics, to be able to take that to commissioners is very, very important. It's a way of being able to identify that if you leave a person alone with no help whatsoever for conditions such as OSDD and DID, that actually the cost to the local health economy is great, and to introduce something, the cost to the local health economy reduces. Now, this is published research. This is something that anybody can do by keeping a record of the number of appointments that they have, whether it's for blood tests or whether it's for examinations or whether it's for referrals to various different clinics or it's hospital use, accident and emergency. If you're able to work out over your last 3 or 4 years how many of these things you may have had to access in order to manage your own condition, in order to basically, stay in one piece and try and cope as best as you can do, that you're using all these resources, there are costs attached to this. You can speak to GP practice managers, you can talk to health insurers, and you can get an idea of how much money may have been spent. If you use that as an argument to be able to put towards a funding application, it makes sense to fund therapy. And there are a number of different centres, of which we are one, that can provide this. The local mental health services could also be providing this. It comes down to geography. Where you are determines how likely you are to receive treatment. But this is a way of being able to take to commissioners, the people who spend the money on healthcare, as an argument to say that you deserve the therapy for this condition, because without it, it has a negative impact on local health economies. Now, it's a very black and white model of looking at things, but actually it's in a language that commissioners can understand, which is about cost. And while I know, and while you know, watching this, is that the actual cost is much broader than that. It's this sense of self, it's the nature of who you are as a person, it's your potential, your ambitions, your life, your education, your relationships, your employment, your friendships, your fun, your enjoyment of life. All of those things matter hugely. But the argument is about cost, and that if a service is being used that is not helping you, that has a cost. It is simply more cost effective to use services that will help you. So, in summary, this is a resource. It's a published, peer-reviewed article in the scientific journal that is used to demonstrate that actually providing therapy for people with complex dissociative conditions is cost effective. So I do encourage you to have a look at the abstract. If you're able to get hold of the article, that's brilliant. Even if you just reference the article in communications with commissioners, then that might get you somewhere. So I hope this video has been useful, and please like and subscribe for future content, and leave any comments in the comment section after the video, and I'll be interested to see what you think of this. Okay, in the meantime, take great care.